Hello. Today I'm going to talk about an intervention for traumatic stress, cognitive processing therapy, developed to treat post-traumatic stress disorder related to interpersonal violence. Since its initial development, CPT has been utilized with numerous traumatized groups across the U.S. and the world. Yet, there's some evidence that PTSD may not be the most useful conceptualization of traumatic stress among individuals in non-Western or collectivist cultures, particularly for those who experience natural disasters. However, emerging evidence suggests PTSD may be relevant for interpersonal violence in these populations. Given this, the current video will focus on PTSD and interpersonal violence, and a separate video will focus on alternate conceptualizations of traumatic stress. Most individuals who encounter potentially traumatic events are resilient. However, in some cases, traumatic experiences overwhelm one's coping resources. Traumatic reactions vary by individual and are culturally based perceptions of the event, including one's sense of control, predictability, and meaning of the event. Potentially traumatic events may occur in a range of contexts, including natural disasters and interpersonal traumas, such as sexual assault, child maltreatment, or intimate partner violence. Interpersonal traumas are often experienced in isolation and typically involve known perpetrators. This may disrupt perceptions of trust, increase levels of self-blame, and decrease the likelihood that the trauma survivor will disclose the experience or seek support. Distress following exposure to traumatic events is influenced by age, gender, nature of the event, and cultural beliefs. Negative outcomes, such as anxiety, depression, and suicidality, substance use, and PTSD have been widely documented in Western cultures. Included in the DSM-5 and the ICD-10, both diagnostic systems indicate PTSD involves intrusive, trauma-related experiences, such as nightmares or flashbacks, persistent avoidance, and generalized hyperarousal, such as hypervigilance and difficulty sleeping. Although the validity of PTSD regarding its use outside the Western context has been the subject of much debate, it has been observed among Southeast Asian, Middle Eastern, and South American trauma survivors. In non-Western cultures, PTSD may not be the best conceptual tool for characterizing traumatic distress, given prevalence of somatic symptoms, mourning, and other presentations. However, there is emerging evidence that PTSD may be a useful construct to understand reactions to interpersonal violence. Before talking about intervention for PTSD, I would like to discuss the scope of interpersonal violence. Consistent with global prevalence rates, a study by the Ministry of Women and Children in 2007 showed rates of child maltreatment in India range from 49% for emotional abuse to 69% for physical abuse. Subsequent research noted rates of child abuse in India ranging from 41% for physical abuse to 60% for emotional neglect. In addition to child abuse, intimate partner violence and sexual violence against women is also prevalent in India, with 40% of Indian women reporting IPV in their marriage. Although research in Western nations documents an association between IPV and mental health difficulties, such as PTSD and depression, little published research has been conducted on the consequences of IPV in India. Research on IPV in India is consistent with studies of women from Western countries. In 2009, a study found that women in India who experienced IPV are at higher risk for PTSD and depression, with approximately 14% of women having PTSD and an additional 20% reporting subthreshold symptoms. Women exposed to IPV report higher rates of depression and PTSD compared to non-abused women, with severity of violence predicting symptom severity. Given the globally high rates of child maltreatment and intimate partner violence in women, and the links between these experiences and development of PTSD and/or depression, it will be important for clinicians to be aware of available interventions to treat conditions due to these experiences. Trauma-focused interventions typically proceed in a sequenced nature through 3 stages: safety and stability, exploration of trauma, and recovery and resilience. Safety and stability are the prerequisite for trauma therapy and involve ensuring the client is safe and ready to engage in active treatment that focuses on the traumatic experience. In this stage, there is a focus on tailoring the explanation of PTSD symptoms by using examples from the client's experience. It is important to normalize traumatic stress as a natural and normal reaction to an overwhelming event, and to explain that clients can get stuck in the process of recovery, which may result in psychopathology such as PTSD. There are numerous empirically supported interventions available for PTSD, although few provide cultural adaptations useful for evidence-based practice. One option for culturally adapted intervention is cognitive processing therapy, or CPT, a type of cognitive behavioral therapy designed to promote recovery from PTSD. Studies of CPT have demonstrated improvement in symptoms of PTSD and depression, as well as guilt, shame, and self-blame. Developed to treat PTSD following sexual violence, research suggests that CPT is also effective for a wider range of traumatic events, including child sexual abuse, intimate partner violence, and combat. CPT for PTSD is a structured intervention that includes components commonly found in behavior therapy, such as exposure, and aspects of cognitive therapy, such as Socratic questioning and cognitive restructuring. Components of CPT include psychoeducation, explanation of the etiology and maintenance of PTSD symptoms, exploration of the impact of trauma on the client's belief system, identification of stuck points, areas in which the trauma survivor's belief system is unable to adaptively accommodate the experience, exposure to traumatic memories, and discussion of trauma impact along 5 themes: safety, trust, control, esteem, and intimacy. Within the U.S., CPT has been used successfully to treat ethnically and racially diverse trauma survivors, including African Americans and Latina clients. Ethnic minority clients may be more prone to premature dropout from therapy, but still maintain treatment gains equivalent to their European American counterparts. Outside the U.S., CPT has been used in numerous countries, including Cambodia, Japan, Hong Kong, Iraq, and Israel. One example includes a controlled clinical trial which compared CPT and an individual support condition for female survivors of sexual violence from 16 villages in the Democratic Republic of Congo. To culturally tailor the intervention, village leaders were consulted for translation of treatment concepts and to encompass relevant cultural norms. Laypersons within each village also were trained to provide the intervention. Both groups improved following treatment, although reduction in PTSD and depression was significantly better for the CPT group. Improvements were maintained over a 6-month follow-up, at which time 9% of the CPT group and 42% of the support group met criteria for PTSD. Most researchers using CPT outside the U.S. note few necessary modifications beyond translation. However, given the emphasis on meaning-making, it is crucial to use a culturally informed approach. In other words, techniques such as cognitive restructuring are appropriate for use, but the content of actual beliefs will vary widely by culture. When cultural adaptations were indicated, it was typical to incorporate modified content regarding basic assumptions, beliefs regarding gender roles, and religion. Thus, clinicians must be knowledgeable of client beliefs in domains of cultural diversity to deliver this treatment effectively. Interested individuals are encouraged to access resources that will be posted with this video to learn more about CPT, including information about free online training opportunities, as well as research on the cultural adaptations of this intervention. Thank you for listening. Please be sure to look for another video in this series that focuses on alternate conceptualizations of traumatic stress, including post-traumatic growth.